E.H. Chan School of Public Health, Michael Mina, has cast a cold eye on what the Minister, Stephen Donnelly, the CMO, Tony Holohan, and Professor Philip Nolan of NEFIT have been saying. And he wants to clarify the role that antigen tests can play and how they differ from the information that a PCR test would provide. Professor Michael Mina joins me on the line. Good morning and welcome, Michael.
Well, thank you. Happy to be here.
Now, Michael, let's start with PCR tests because our public health experts always refer to that as the gold standard. What can it do, a PCR test, and what may it not do?
It's a great question. When we think about testing for public health, we have to think about and ask the question, what is the use? Why are we doing the test? And only once we determine why we are doing the test can we say what is the gold standard. The PCR test is an immensely powerful and very sensitive tool to detect the RNA, the genetic code of this virus. But it doesn't necessarily correlate or mean that if you are positive, you have any live or infectious virus in you that is a danger to other people. And what that implies, or what it really suggests, is that many people will be detected for their first time on a PCR test long after they have actually been infectious, and they likely don't need to isolate anymore. It's not a specific test. It's very poorly unspecific when the question is, am I infectious?
So the PCR test will detect if you've just contracted the virus and it's beginning to get a foothold in your body. It'll detect it at that point. It'll detect it when you are in the throes of it. But it will also keep on detecting it long after it's now no longer infectious in you and you're sent home maybe when you fail the test. You're positive for the virus, but you're actually perfectly safe to go to work, to school, to college.
That's correct. And we've seen this. For example, this has been known. It just takes a little bit of putting the pieces together from, for example, the CDC in the U.S. And that's that the CDC has suggested that after people are done isolating, that they don't get a second PCR test. They don't go and get another one because they will often likely remain positive on the PCR for a long time after they are done with their isolation period. And in general, what we find is that PCR stays positive for about 3 times or 4 times longer than somebody's actually infectious. And the marginal gains, the amount of time that it is positive at the beginning, before somebody becomes really infectious, is only hours, maybe a day. And so really, you're getting a lot of people after they've been infectious because of the lack of specificity for that particular use case, which is transmission. Even though it's very, very good to diagnose somebody, just like a physician would want to diagnose, a physician wants to diagnose a patient the same way that a forensics detective wants to go back to a crime scene and find every shred of blood or hair, and they use PCR to determine whose blood that is, but the crime is completed. It's just going back and asking what happened here. That's what the PCR is very, very good at.
So if you were wondering, I felt pretty rough 2 weeks ago. I wondered, did I have COVID? You take a PCR test and it'll find shreds of the virus still there and say, yes, you have had COVID, but you're fine now. Thank you very much. If you take another test, which is what we're coming to, the antigen test, which will tell you whether you're infectious or not.
That's correct, although there is a different way to use the PCR test. The PCR tests also have a quantified number associated with them. And so if we were more savvy across the world about how we are using the PCR test, we could infer from this very, very sensitive, powerful test if somebody does have a very high viral load, using the PCR test by looking at what's called the CT, or the cycle threshold number. But in general, we haven't seen that really be utilized in any real rigorous way. And the antigen test that we'll come to, as you said, is a very specific test for this question, am I infectious?
Now, on this program, we've been pushing that particular idea that the usefulness of the antigen test indicates when you're infectious. In other words, when you isolate, when you go home from college, school, work, or whatever, because you don't want to give it to your co-workers. What do you make, though, of our public health officials saying that people who self-test using an antigen test, it may not be the right test, said our minister, they may not use them in the right way, or they may take a different meaning from a negative result?
Yeah, well, the main point is that the tests actually do work. They do work. They work very well when the question is, am I infectious? What I've seen is that some of the officials making these decisions in Ireland and, frankly, across the whole world have made the wrong comparison. And what I've seen in Ireland is they're looking at a review that was done called the Cochrane Review. And that looked at a whole number of studies and found somewhere around a 50% sensitivity of the antigen test compared to PCR. But what our research has uncovered is that loss in sensitivity is all after people are infectious. So and they're absolutely very good tests and very sensitive to detect current dangerous infectious infections at the time, and they give a fast, immediate, accessible result. So I think to not want to use such a powerful test in this pandemic because you're getting swayed by inappropriate comparisons to PCR is really an unfortunate thing in a crisis like this.
So if we take what they did, they test people with the antigen test and they find out how many people are positive and therefore infectious. And then they test the same cohort of people with PCR and they find that the antigen test appears to have missed a whole pile of people who are positive with PCR. What they should be drawing the conclusion is that the people who aren't positive in antigen are people who have had COVID and are past the infectious phase.
That's exactly right. It's really no more complex or complicated than exactly that. People who are not positive on the antigen test but are on a PCR are almost always past the infectious phase.
The declarations by our chief medical officer, the comparison or allusion to snake oil by Professor Nolan, what did you make of those kind of statements?
Well, it's just not helpful. The public, we have to understand that, while this can get fiery and charged up on Twitter, we're talking about people's lives here. And these are tools that, when used appropriately, can save lives by preventing spread. They can prevent spread in schools, in the workplace, in the community. So to deride a potential tool, a tool that has the potential to save somebody's life by preventing an outbreak, and call it snake oil, it's a net negative to public health. Those types of comments aren't useful in any way, shape, or form. And we have to remember that we're all on the same side here. It's the interpretation, the data. The data is saying something different versus what or I should say the science is saying something different versus what folks like Nolan have inferred. But I do believe that we're all on the same side, and it's sad to see it get so charged that they're calling a very powerful test in the middle of a pandemic snake oil. It's just not appropriate.
Now, what do you make of the criticism that people can't be trusted to do it properly themselves? That, okay, in a controlled setting where you have nurses or medical staff helping people with their antigen test, okay, maybe you can rely on it there. But of course, Lidl, the supermarket chain, and others are selling antigen testing for people to do themselves. It would appear that the public health people don't trust people to do it correctly themselves. What do you say to that kind of criticism?
These tests are very simple. To that type of criticism, I would say to the public health folks and the decision makers in Ireland to don't look at that as a barrier to a good tool ask, what do we need to do to remove that? And if that is a concern, then ask the news anchors on the media, ask the newspapers to show how to use these tests. Make good public health messages. Don't call them snake oil. Instead, say, hey, these are very powerful tools. If you have an outbreak that is happening in your community, these are extremely powerful to suppress that outbreak. And this is how you use them. And be teachers to the public. Work with the public. What I've seen in Ireland and elsewhere across the globe is that policymakers are often thinking of the public as the problem. The public is not the problem here. The public is the only solution we have. If we don't engage the public very early, very well, if there's a problem with how people understand how to use these tests, fix that. That's education. We can do that. And it shouldn't be holding up a very good tool. And the other side is that there is not a lot of education that needs to happen. The tests are simple. People can do them. If not on the very, very first try, then they'll learn the second time, and the third one will be a whole lot better than the first time. So it's very simple solutions to these problems.
In my experience of people who have actually bought antigen tests, and even the cheapest of them will cost about $6 for each test in the supermarket. If you order them from other companies, it might cost a little bit more. They tend to be people who are being very careful about themselves, trying to do the right thing. They're not kind of feckless people who are looking for permission to go partying. And that's the issue maybe that we have with public health, that they are not giving people the opportunity to do the best they can to protect themselves and their loved ones.
That's exactly right. And this is not new, unfortunately, to public health and to physicians. If we go back to seatbelts, when seatbelts first came around in cars, the public health community at the time was saying, we can't put seatbelts into cars because people will drive recklessly. Obviously, that's remarkably short-sighted today. We understand that. When pregnancy tests were starting to go into people's homes and they were being held up from getting into over-the-counter, off-the-shelf purchasable tests, the public health community was saying, and the medical community was saying, we can't give women pregnancy tests. They would never know how to interpret or use the test appropriately or really make sense of it. This paternalism in public health is nothing new, but it's time we stop that type of paternalism. Let's not hold up important tools in the middle of a pandemic because we want control. People, it turns out, are the solution, and they understand how to use simple tools. Sometimes we just have to explain it, and the decision makers are in a position to really help that process along.
If we were to use, therefore, antigen testing in a routine way, on university campuses, for instance, or in schools, or on the factory floor, how often, to be sure of catching those infections, would you do it in the working week, for instance?
So when cases are raging and when there's outbreaks and there's not a ton of vaccination, what all of our mathematical models have shown is based on the way the virus grows and transmits in people, that if we test everyone twice a week, or just a fraction of people, if we test half of the people in a community twice a week with rapid tests and ask them to isolate if they turn positive, that is enough to suppress the outbreaks in a workplace or in a community, to stop the outbreak from growing. Maybe one person might infect two, but then those two people will very likely be caught before they have a chance to go on and infect. So the reproductive rate of the virus in the community stays below 1, and that's all we need to do to completely mitigate outbreaks. We just have to keep R below 1, and these tests twice a week amongst a large fraction of the community can do that.
Now, Michael, sometimes we get reports of false positives with antigen testing. How do you cope with that?
Sure. So the first thing is that many of the rapid antigen tests have very, very low numbers of false positives. For example, we just finished a very large study using hundreds of thousands of rapid antigen tests, the ANOVA test, and we found less than 1 in 10,000 of those were falsely positive. Less than 1 in 10,000. Another study using the Abbott test has found something very, very similar. Less than 10 in 300,000. So these are very small numbers of false positives. But if you're concerned about a false positive, it's a rapid test. Test a second time. Especially if you have a second test from another company, then the chances of both of them being falsely positive is exceedingly low. So we have very simple solutions here. They are rapid. We should use them for their abilities. And in this case, the speed is important. If it's truly a false positive that somebody's getting, then when you test again, it should be negative. And you'd know in 10 minutes if the first one is false positive. But again, I want to stress that the newer rapid antigen tests, these paper strip tests, have become very, very accurate on the specificity side. So false positives have become much, much less of an issue.
We have a situation here where people who cannot work due to COVID-19 are paid what they call the PUP payment, but it's €350 a week. So we're talking about over $400 a week. And, you know, there's a simple calculation. If a couple of antigen tests a week are costing you maybe less than $15 and you get people back to work more quickly, you save a hell of a lot of public money.
Absolutely. What we have found, I've worked with a number of economists here at Harvard to ask those types of questions. What we found is across the United States, for instance, had we rolled out rapid tests in the late summer, we would have potentially saved hundreds of billions, if not trillions, of dollars through that type of program. And it would have only cost the United States, the whole of the U.S., around $10 billion to put in place for frequent testing. The economics work out here.
So finally, on a kind of a one-to-one basis where someone is saying, I'm going to test myself today with an antigen test, and if I am negative, I feel confident I can go and see my aging parent or grandparent, maybe keep social distance, but I can have a cup of coffee or tea with them and be sociable with them for a while. Is that a fair statement? Is that safe to do?
Absolutely. Especially what I would recommend is if you're using it for that purpose, use the test as close to the time of visitation as possible. I would rather, if I'm going to visit my elderly grandparents in a nursing home in their mid-90s, I am going to be much better off if I use a rapid test 20 minutes before walking into that door than if I do a PCR test 3 days earlier. They're not even close to comparable. The rapid test, if your question is, am I infectious now or in the next few hours, a rapid test is extremely powerful tool to ensure that at that moment in time, you are not infectious. Whereas if you use a PCR 3 days earlier, you could literally be at your peak of viral load the moment you walk into that door, even though the PCR test 3 days ago was negative.
The last question really is about the finish line. We all feel that we're galloping towards it. The vaccination rollout in the United States is going apace, even though there's a huge reluctance among certain cohorts not to be vaccinated. We're doing quite well here. Many people have had their first shot. Some have had their second shot. Out of a population of 5 million people, including children, we've already administered more than 2 million doses of vaccine between first and second doses. Is there a place going forward for continuing use of the antigen test?
I think there is. I think we're going to shift from needing to do frequent rapid testing to suppress and prevent outbreaks to being able to use them in a much more reactive fashion to have very quick dynamic reactions. If even in a place that is largely vaccinated, an outbreak starts to emerge with some of these more transmissible variants, these tests can be quickly adopted, used very, very fast. And if there's an outbreak, maybe you give everyone a test every day for the next 7 days. And then you're done with it. The outbreak stops spreading. And so these can be used for very rapid containment and control in a way that the laboratory tests, which need a lot more kind of infrastructure to make sure you have the contracts associated with them, the rapid test can just be stocked. And if you have an outbreak in a school, just start using them. Or if people already have them at their homes, they can get a text message that says, hey, the community transmission has ticked up again in your community. We hope that before sending your kid to school or going to work, you use a rapid test and do this for the next week, and then we'll be done with it. These can be very dynamic tests, and we can use them as our preventive mitigating strategies moving forward, even in the context of vaccines. But it doesn't need to be this serial testing all the time in the future. I don't want the populace to be in testing purgatory. I just want us to have a tool at our disposal that's very powerful if and when we need it.
Michael Mina, Professor of Epidemiology and Immunology at the Harvard T.H. Chan School of Public Health. Michael, thank you very much for joining us on our program today.